Thank you very much. It's a pleasure for me to be here today. Among friends, I feel. BDMS has a very special place in my heart because in 2007, I think sometime in June of 2007, I was part of the JCIA survey team that was here to accredit the hospital and the 3 other hospitals in the network in Bangkok. And our friendship with many of the team that were here at that time still continues to this day. And so I'm very happy and very honored to be here today to speak at your very important academic conference this year in 2018. It's my first time to be here for this conference. It's incredible to see how BDMS has grown and developed over the last 11 years. And it's great that you have this conference to share the learnings that you have, both in terms of advancements in clinical practice, as well as advancements also in other areas with your fellow colleagues. And I think that's very important because that's really the way that the organization as a whole develops over time. And I think it's extremely important to be able to grow and develop the people as well, who are, to me, an extremely important competitive advantage for your organization. If you can see from the slide, the opening slide, I made a small change to the title. Instead of saying standards being at the core, I changed it to quality improvement, of which, of course, standards are going to be part of it. But as I was explained more in my presentation, I think it's more than just standards that are going to be important if an organization is going to be able to have sustainable or sustained competitive advantage in the healthcare space. It's always a big question among organizations. How do I continue to be successful even though I have been successful already right now? How do I continue to grow and be successful? And so we'll talk a little bit about that later on during my presentation. So let me first start. Of course, you know very well who we are in terms of Joint Commission International. I'm not going to tell you more than that, except that important information is that we have accredited now more than 1,000 organizations around the world. We will be having a special ceremony sometime next month in Bangkok, for which, of course, we'll be inviting many organizations in Asia, including in Thailand, to attend with us to have this celebration. But we are already in our 19th year of accreditation. Next year, we will be celebrating our 20th year of international accreditation globally. We first accredited our first organization in 1999 in Brazil. And I was just there maybe about 2 months ago for their re-accreditation survey. So they continue to be a customer for ours, even though it's already been 19 years. So it's a very long time, and I was happy to hear from their hospital director that I should already start booking my air ticket for their next survey 3 years from now. It's wonderful for our organizations for me to meet our organizations and talk to them about their experiences about JCI accreditation and why is it that they continue to seek JCI accreditation. These are some of the comments that they come up and they tell us when we ask them why exactly you become or you are JCI accredited. And I think the most important thing, the thing that I want to hear, especially as Vice President, is that we are there not just to tell them where the problems are, but also to help them and work with them to improve and to educate. That is more important to me rather than just being there telling you what your problems are. A lot of times I think the organizations themselves already know what the problems are already without us coming to tell you what the issues are. And especially I think if you think about it, how much can we know even though we may spend 5 days with you? You probably know much better what the problems are in your organization. I think the benefit sometimes when we come in is sometimes as outsiders coming in, we may ask questions that you may have never have thought about because you've done this all the time for many years or many times. So you may not think that it's unusual, or you may not think that it's extraordinary or out of the ordinary. But that's why sometimes the external eyes are very useful. But I think the more important is being able to work with organizations to be able to help you, to inform you about what learnings you can have from others, but also to help you improve. Other organizations we've heard about from Asia is that competition in healthcare in some of these countries have become very intense, very strong. And I think it's no different, of course, in Thailand. Thailand, you have a number of private hospital groups. Thailand, of course, you also have many private hospitals. Of course, I know BDMS is now very, very strong. It's now the biggest or one of the biggest private hospital groups in Thailand. But for many organizations in many countries, it's becoming more and more of a standard rather than something that's exceptional. We were talking about this with some of my colleagues in BDMS, and 11 years ago, you only had 4 hospitals that were JCI accredited in Thailand. Now I think you have 17 all over Thailand as well and other places. So the numbers have really grown. You know, we talk about how we have more than 1,000 all over the world now. So the numbers really have grown, and as organizations get more knowledge, as they start to understand our standards better, as healthcare continues to advance and improve, we continue to see that more organizations are able to make those kind of achievements as well. So it's becoming more of a standard. And finally, of course, we hear organizations who want to really try to compare themselves or benchmark themselves against some of the very best organizations around the world or in the United States. And our standards, of course, as you know, they are very, very similar to what is required for all hospitals in the United States. So our parent company, the Joint Commission in the United States, they accredit about 4,000 hospitals in the United States, but also many other types of organizations. So they accredit about 22,000 organizations just in the United States alone. They are, of course, therefore, the oldest because they were set up in 1951 and the biggest national healthcare accreditation program in the world. And so they have a lot of expertise and knowledge in terms of that. But our standards internationally do follow quite closely with where they are going as well. So some of the advances that you may see that they have in their standards, we also continue to add and into our standards when we do our revisions once every 3 years. And of course, if we're talking about Thailand, the whole topic about medical tourism, of course, is something that's very important. Thailand, of course, is one of the most important countries that are in the medical tourism kind of space. And of course, if you look at some books like Patients Beyond Borders, they talk about how organizations need to have JCI accreditation if you're looking for treatment or major surgery. We even have insurance brokers like Clemens Worldwide Insurance that says that on their website, be sure to wherever you're going is JCI approved. So you can see that there is a lot more organizations now that know about us, know about what we do, and how important we are to healthcare and to quality of care. So going to talk about this whole topic about medical tourism, I just want to set the stage in terms of talking about who the players are, the major players are in terms of medical tourism. I mean, I really don't have to talk to you too much to tell you about who the main players are. Many of them are very well known. Maybe a few you don't know about so well. So Thailand, of course, very important. In the area in Asia, you also have India, who's a very big player in medical tourism market. You have Malaysia. I haven't put in Singapore, but everyone knows that Singapore as well treats many patients around Asia. But if you look at other parts of the world, like South America, Brazil actually does a lot of medical tourism. So a lot of people from South America, as well as in North America, like in the United States or Canada, they go to Brazil, especially for cosmetic surgery. I know we hear that Thailand, a lot of people come here for that, but in South America, Brazil is really the center of cosmetic surgery in the South American continent. And, you know, in Brazil, they have many beautiful women who are Miss Universe or Miss World. They really very appreciate beauty and appearance in Brazil. So the cosmetic industry, cosmetic surgery industry over there is a very large and competitive market. Another place that people don't really think about is Costa Rica. Costa Rica as well does do quite a bit of medical tourism now. It's not as expensive a place as many other places, and it does have many interesting tourist attractions aside from just doing healthcare. And so it's slowly and quietly built up quite a big profile for medical tourism over in Central and South America. Another place in Europe you don't hear about a lot, but actually has been in the news recently these days, is Turkey. So Turkey is somewhere between Asia and Europe. If you think about it, with the decline of the Turkish lira, the currency over the last few days, actually healthcare there does become even more attractive because the currency exchange rates have gone down quite a bit because of the trade situation that's happening over there. But it means that all of a sudden healthcare and trying to do surgery or other kind of medical procedures there becomes a lot more sensible and cost effective. So these are just some examples of medical tourism country leaders. The issue, of course, is what and how do you derive what we call competitive advantage? How do you, both as a company or as a country, be competitive with other companies or countries? And this concept of competitive advantage was actually derived or described by a very famous person called Michael Porter. I'm sure you may have heard of his books on this, or may have read about the book itself, but he described this concept in 1985. And he analyzed, or he looked at how many companies and how they were able to make sure that in spite of the success they had, how did they continue to create success over time? And he came up with three very important areas of factors that these companies focused on or spent a lot of time trying to do. And these three areas are, number one, cost leadership, number two, differentiation, and number three, focus. All right? Three somewhat very basic company examples, but similarly, you can actually be able to therefore elaborate and explain a lot of things in terms of what that means for a company. He was looking basically at business companies, but you can use the same ways to describe what countries need to do in order to compete against other countries. So when you talk about countries like China, India, Thailand, Malaysia, Singapore, you don't talk about competitive advantage because you're not companies by itself. But the same kind of traits or the same kind of qualities do give countries what we call comparative advantages over each other. So they basically try to use those in order to be successful as a country as well. So I want people to think, for example, about why one would go and do manufacturing in China versus doing manufacturing in the United States. If you think about how over time, since the 80s and all, how organizations in the United States, they started moving all their manufacturing over to China. And now you can see that China manufactures about 5 times the amount of products that the United States actually exports to China. If you look at the trade imbalance between them, you understand that how different it is nowadays. But China, therefore, uses what they call cost leadership in order to make sure that they have a comparative advantage over the United States for manufacturing. So what that means is that in order to manufacture a product, it costs so much less in China than to make the same product in the United States. So if you buy an Apple phone, for example, you all know that Apple is designed and made by a US company, but all of the iPhones are not made in the United States. They are all made in China, because the current CEO, Tim Cook, he realized that there is so much bigger advantage for him to produce the iPhones in China. And it's not only because it's cheaper, it is also because in order for them to export the iPhones out from China to other places, it's also very easy because the infrastructure is very well developed in China. They also have all the suppliers and all that supply all the parts of the iPhones located in China. So it's much more than just low cost. So if China, if Apple decides they wanted to find somewhere else that was cheaper, for example, India, to make an iPhone, yes, they could. But if you understand in terms of infrastructure, in terms of exports and all that, India right now doesn't have the superiority or advantage over China in terms of the infrastructure to export all its products all over the world. So that's why at this time, China uses the advantage in terms of cost, in terms of therefore having a comparative advantage over the other countries in terms of trying to achieve leadership in terms of exports and all that. But the thing about cost leadership is this: there will always be somewhere else that will be cheaper than you, all right? Over time, as your country develops, as your country matures, your people become richer, more affluent, your people have higher expectations. They also have higher expectations of higher salaries and all that. So over time, your cost leadership will always go down. Your cost will go up. So that is what they are finding is a problem now in China, because salaries are rising quite rapidly over time, and they find that they have to find other places to start manufacturing and doing other services. So more and more now, you're seeing, for example, for manufacture of clothing, textiles, and all that, they're starting to move to other countries that are cheaper. Vietnam, Cambodia, going to Bangladesh, and soon, I think, eventually they'll be going out to Africa, which is probably the lowest cost area right now. So there will always be places where it will always be cheaper, especially as you get better and better at what you do and your people get better. The question also sometimes is that sometimes cost leadership is not within your control. So all of a sudden, right now, when Turkey is at this issue with a trade imbalance with other countries and with the United States, all of a sudden their currency becomes much cheaper. But when their currency becomes much cheaper, it also means that exports like healthcare and other things all of a sudden become much cheaper. And you have no control over such currency moves and how that is. So sometimes, therefore, if you focus on just purely on cost, to me, it's not a sustainable competitive advantage. You can have that for 3 years, 5 years, but as your country develops, as your company develops, that cost leadership becomes more and more difficult over time to maintain. So you cannot, therefore, Michael Porter says, you cannot just use cost as a way to be able to be successful and to be competitive. Because for sure, you will always have someone out there who will be cheaper than you. So the other things that you have to do then is in terms of differentiation and focus, which is where I talk about, therefore, in talking about deriving sustainable competitive advantage, especially for healthcare organizations. And I talk about it in terms of using the concept of quality improvement at the core, and that it can also achieve all three areas or target all three areas. So I want to talk more about that. So first thing we talked about was cost leadership. So we're talking about, of course, earlier we're talking about cost of living, cost of salaries and all that. But part of the thing in terms of thinking about cost leadership as well, and Michael Porter talks about it, is also the company's focus on how they make their processes much more efficient and also try to improve and cut down the cost of their processes and how they deliver a service or product to make it more and more lower cost. I think that is the focus when we are talking about current companies that have been successful and how you need to be even better. You need to be able to focus on that. And we think a lot about that and talk a lot about that, especially when we talk about JCI standards, because we focus on a few things like standardization. So instead of having 50 different types of gloves in your corporate group, you have 5 or fewer, right? So when you have 50 and you bring it down to 5, it means that you have much more volume in terms of each type of glove, and then it means that you have much more economies of scale and you have much more bargaining power with each of your suppliers, because now you're not buying 50, you're only buying 5, and you have increased numbers that you're buying from your suppliers. So therefore, you're changing the dynamics or changing the relationship you have with your suppliers, and you have much more of the advantage in terms of purchasing power when you are buying more of a certain specific product. So we talk about standardization. We're also talk about when you have standardization, it also means that you simplify. It also means that you eliminate variation. And that, as I'll talk about it later, is very important if you're going to improve processes. Because if you don't improve and standardize your process in the first place, you cannot start thinking about improvement. And finally, in terms of cost leadership, is this concept of eliminating waste. Trying to cut away unnecessary process steps, trying to eliminate times where you rework or times when you are actually waiting for someone else to do things. The Japanese have a very, very good way to describe it. They call it muga. Really, it's really trying to eliminate waste in all the process. I think the Japanese are the ones who have done that the best. And they focus a lot on trying to eliminate waste from their processes. But in this whole area of quality improvement, then focusing on standardization, process improvement, eliminating waste, that's really where you can get through the cost leadership, aside from just focusing on your cost of salaries, cost of your expenses and all that. That's another way. I think the second way when we talk about healthcare organizations in terms of differentiation, very importantly, of course, is innovation. And the other way, of course, is improving quality itself of the service of care. And I think a very good example that you're doing in terms of innovation I'm seeing, at least in BDMS, is putting in place advances in technology, in practices and all that. A conference like this is a very good example of how you talk about really being able to share the advances and learnings, both in processes, but also implementing and putting in place new technology in the organization. I think I see that happening very well in terms of improving quality, in terms of trying to do quality improvement projects, whether you use PDCA, whether you use PDSA, whether you use Six Sigma or other kinds of processes. But the idea is that using the quality and trying to improve that, in using that to differentiate you from your competitors, is the second way that healthcare organizations, I think, need to focus on and need to try to do. And by using quality improvement at its core, it's the way really to be able to focus and to achieve that. And finally, in terms of focus, what Michael Porter really talks about is making sure that your company or your company doesn't just provide services for all your customers. You know what your customers are going to be, what you're best at in terms of services for your customer, basically targeting a specific patient area or patient niche that you want to develop. So talking about BDMS in terms of the centers of excellence and all that, you've identified which areas that you want to develop. You've identified which patient groups and populations that you can do a really good job at. You've identified which patient populations are actually a better community to serve, and also being patient-centered and understanding what patients need for that. That really is, to me, focus. So when you put quality improvement at the core, therefore, that really covers a lot of the aspects that Michael Porter has talked about, really in terms of trying to derive a sustainable competitive advantage for BDMS as a company, but also potentially what Thailand could do as well if it wants to generate a comparative advantage over other countries. It is not enough to just focus on being the lowest cost provider in the region or in the world, because there will always be someone or somewhere that's going to be able to provide a lower cost than you. It's always over time you'll find that the low cost thing will always run out, and you've got to figure out other ways like differentiation and focus in terms of trying to achieve quality. Now, I want to go back now to talk a little bit more detail about quality improvement and improving quality. And we always talk about what it is that we want to do in terms of improving quality. We talk a lot about that. I want to make sure that when people talk about quality improvement, we talk about how we're trying to do this in a very realistic, systematic, stepwise process about improving quality. And so I try to use this example of a quality journey and how to reduce errors in your process as a way to give a very good understanding example of what I'm trying to say. Now, one very good way, or one very measurable way of being able to see that you've improved quality is to try to reduce the errors that you have for a same process. If you talk about it in Six Sigma kind of terms of methodology, we're talking about errors per 100 or 1,000 or 10,000 or 100,000 or whatever. All right. If for those of you who understand the Six Sigma kind of terminology, when you talk about Six Sigma, you're talking about 3.4 errors per million opportunities. To me, sometimes when I explain this to people who are not in the technical area, I tell them, well, just reduce your errors to 1 in a million. That's close to where you're talking about when we talk about Six Sigma. But if you can have Six Sigma, you can have 1 Sigma or 0 Sigma as well. So as we talk about errors, if you talk about 1 Sigma is around 2 errors out of every 3. So basically having an error about 2/3 of the time. 2 Sigmas is about, I think, about 6 in 100 or 6% of the time. 3 Sigma is about 6 in 1,000, and so on and so forth. But in order to improve or cut down in the errors, there is a certain methodology in order to do this. And we don't explain this when we talk about this a lot of times in trying to do quality improvement, but explaining it in terms of accreditation and standards and improvement, if you look at improving the quality journey, going from 0 to 2 Sigma, many times we focus on improving what we call doing the basics and getting the basics right. All right. So if you look at it in 1919, the American College of Standards came up with the first ever accreditation standards for all hospitals in the United States. In 1919, that's about almost 100 years ago, there were only 5 standards for hospitals in the United States, right, which they came up with. They surveyed about 632 hospitals at that time, and I think they found that almost 50% at that time didn't have the basic 5 standards that are listed here. These are what we call the core basics. The interesting story at the end of it was they were so horrified by the results of the initial survey that they burnt the results for that survey in the hotel fireplace, and they never shared it with anyone. We're talking about this now, but you understand that true accreditation only happened in the United States in 1951. So it took them about 30 years or so or more in order to get comfortable with the idea that hospitals needed to abide by certain basic standards in order to actually have improvement. But if you talk about then fix the basics right then, 5 standards and all that, I think for many organizations around the world and in Asia, the requirements that you have already for licensing, they already more than cover what is already required by hospitals, even in 1919 in the United States. Now, of course, these 5 standards to everybody in the room sounds like very simple and basics. So when we talk about them fixing the basics, getting a 2 sigma level already, that's what we're talking about, trying to put in place many of the structural requirements, the basic requirements to have in hospitals. And I think that for BDMS for sure, but I think many of the Thai hospitals, you are more than over the basics. So now we're talking about what more is after the basic and talk about reducing errors beyond the 2 and 3 sigma levels already. But the way then to improve is really the next step. If you want to talk about improving 3 sigma and over or after, is really you have to actually standardize your processes first, then focus on improvement. So the picture on the left that you see over there, and I'm trying to make sure that I get this right. No, it's not this. Okay, so let me see. Nope. Okay, never mind. If you look at the picture on the right, that is what we call a SPC chart for falls per 1,000 patient days. But that is what we call a process that is not in control. You notice that there are some results that are above the upper control limit. You see that there's a lot of variation in the process. And that is an example of a process, therefore, that is not within control. And we always recommend that if you want to improve that process, firstly, you need to standardize your process first and make sure that that process is within control before trying to really do the root causes and try to understand how to improve it. So it needs to be more the picture on the right-hand side where all the values are within your upper and lower control limits, where your process is within control, and then you can talk about what do you do in order to improve. Because when you have a process that is not within control, even if you put in your interventions at that point of time, you're still likely to find that your process is going to be out of control. So a lot of times we focus on trying to improve. All of us working in healthcare are very enthusiastic. We want to do better for our patients. We want to do good. And so we jump in and try to make improvement when we don't even have a process that's within control. And that, I think, is a problem in many areas. We need to focus first on standardizing first, and then focus on finding out what is the problem, what are the possible solutions, and then implementing that. So it needs to talk about standardization and then improvement. So I think that's the kind of thing that we don't remember when we're trying to do this. Because as you look again at the quality journey, if you're going from 3 and 4 sigma, as this chart recommends, you need to, as you're at 3 and 4 sigma, you really need to systematize the processes, but also standardize the procedures before moving on. So I think that's probably where the area is right now for many of the organizations in Thailand, and certainly I think that's where I think many of the hospitals in the BDMS group are in right now, focusing not just on the basics, but moving on. If you need to improve beyond 3 to 4 sigma, you need to focus on systematizing and also standardizing your procedures, reducing your variation before thinking about improvement, if you're going up to the 3 or 4 sigma quality level. And when you talk about 3 or 4 sigma, we're talking about around 6 in 1,000 opportunities for improvement. But the problem about it is we always talk about, okay, so we've done all this and got to 3 and 4 sigma. Why is it that we still see all these problems and errors in healthcare? And it's true. If you look at it from medications errors, adverse events, wrong site surgery and all that, they all still occur in healthcare. That hasn't changed. And people ask me, why is this so? We've worked so hard for so long. Why is it so that we still haven't seen improvement? Why is it that we still have a chart like this where you can see that in industries that are best in class, for example, in airline baggage handling, nuclear power and all that, why is it that they can run their industry, their companies, their processes at a 5, 6 sigma level, whereas healthcare is running over at 1, 2, 3 sigma levels? The best in class in healthcare is probably anesthesia-related fatalities. That's running at maybe 5 to 6 sigma, but for most other processes they have, you're running still around the 3 sigma level. Why is it so? And I tell people, actually, the problem about it is us. The problem about this is that we continue to rely on the fact that we are humans and we want to keep delivering healthcare, and we keep trying to do processes using humans or doing things manually. The problem about that, however, is that humans make errors. That's a fact of life. It's impossible to get around that. And this is an example of what we call a human error rate table. It basically captures how often humans make errors when they're doing tasks, either simple tasks or very complicated tasks. So the simplest task, which is right at the top, 2 in 10,000, I'm not sure whether you can see it right, is reading a single alphanumeric wrongly. You will only do that 2 in 10,000 times if you do it. And reading a simple alphanumeric means A, B, C, 1, 2, 3. That's reading a single alphanumeric. And even a simple task like that, you will still get it wrong 2 in 10,000 times or opportunities. Why is that so? Because we're humans, right? We get distracted, we think about our family, our wife, we think about what else we want to do. It's boring. You mean I have to keep doing the same thing over and over again? That's the reason why human errors, will always occur no matter how well you design the process, no matter how well you remind people, no matter how many times you tell people you must be careful, vigilant, etc., etc. Humans have a basic error rate. And this error rate will change if the situation gets changed. So if you're just reading one single letter, it's very simple. But if you read or do more complicated things, it becomes more difficult. So of course we have techniques and ways that we help humans be better humans, right? So for example, you have a checklist. Now, when you fly an airplane, right, the pilots will go through that checklist of checking through everything. Why is a checklist very useful or very important? Because it's very simple. When you check a series of things without a written kind of scheme or checklist, you are likely to make an error 1 in 10 times. All right, so that means that if you rely on memory to check things, your possibility of making an error 1 in 10 times or 10% of the time. If you have a checklist, so if you're doing a visual inspection for a specified criterion based on a checklist, your opportunity of error 3 in 1,000 times. So you have reduced your error rate from about 1 in 10 to 1 in 1,000 or 3 in 1,000 just by having a checklist. That's 100-time improvement for that same thing, just using a checklist, all right? And this is not said by me. This is proven by what we call error rate tables. This is why some simple things that we do actually help to reduce errors. But then, of course, people say, well, if you have these checklists and all that, it's very boring, I have to do this and all that. But let me tell you, if those are the kinds of things that help us actually reduce errors. And it's especially important because if there are other situations when you're stressed, right, you can make an error in 1 in 4 times. So 25% of the time, the more stressed you are, the more likely you are going to make an error. And after 1 minute in an emergency, if you're not trained in that, your chances of an error, 9 in 10 times. 90% of the time, you're going to make an error if you're in an emergency situation in 1 minute. That's why when we talk about doing drills and doing emergency drills, you need to think about that because you need to do it so often that it doesn't become an emergency and you can think about it better. So when we talk about electronic medical records and we talk about, okay, you now have digital and all that, how does that reduce error? Let me explain, very simple. 5-letter word like that, so-called, reading, error rate in reading that, 3 in 10,000 times. If you have handwriting like this is Vioxx. I'm sure you can't recognize this Vioxx, but if this is Vioxx, your error rate, 3 in 100. So you've gone from the error just now, 3 in 10,000, gone down to 3 in 100. You've improved the error rate by 100-fold. So that is one example of how you use technology to make humans or help humans be better humans. All right? That's really the idea when we talk about that. We need to help humans be better humans. And giving you, of course, some examples of how we've used technology in healthcare to really help humans be better humans. One example is this Providence group in the United States. So they use their electronic medical records. In their system, the system actually takes all the information, all the data about the patients, and they create what we call an early warning system from all the data that you have in the medical records. The system actually will highlight and flag based on criteria to the nursing team, the medical team, which are the patients that are going to have some kind of adverse incident or where they need to start looking at them much closely. That kind of capability humans cannot do. We don't have the time to sit down and calculate the scores all the time for every patient in your hospital. Imagine how much time you're going to spend. I've seen this happen in the United States. I was most recently in another hospital, I think, in Europe. Their hospital group has already started pooling their electronic medical records and developing an early warning system based on that. But that is another example of how we use technology to help us be better humans in doing that. We talked about CPOE system, prescribing, ordering, entry systems, or closed-loop medication administration systems. That's a very, very good example as well of how we can help technology help us make sure we cut down on medication errors. So in this group in hospitals, Memorial Hermann, very famous hospital in Texas, in Houston, Texas, in the United States, they have more than 1 million medication doses per month, and in some months there are 0 medication errors because of that system, all right? I know that BDMS has implemented a lot of medication technology. You have pickers, you have started to have a lot of the technologies to help you in terms of medication identification and prescription as well as administration. But that's the way that we have to use technology to help us do better when we are doing healthcare. Another example is this group, North Shore University Health Systems in the United States. They use video auditing to actually help improve their compliance with hand hygiene. All right, so there are people actually watching at the areas in terms of the patient care areas to see that the healthcare providers are actually doing their hand hygiene. And that improved the hand hygiene from, I think, less than 10% to more than 90% compliance. And again, all that is very basic, right? We're not talking about rocket science here. This is very basic things that are important. But the important issue then is, okay, so I go from 1 to 2 sigma, then I go to 3 sigma to 4 sigma. We have technology and all that to help us, and that's really good. How then do we go from 5 to 6 sigma? What else needs to be done? Because I can tell you, yes, you can use technology and all that, and you can use technology to help you use as many as processes as you can, but until you get there, you still have to get beyond that. You still need to, more things to do. So the organizations that have reached 5 and 6 sigma are what we call high reliability organizations. And examples of that, aircraft carriers, flight control, aircraft flight control areas, nuclear power industries and all that. They're called high reliability organizations. And there are 2 researchers that have done a lot of work trying to analyze what makes the high reliability organizations so different and so much better than normal organizations. And they determined that they had 5 different areas of characteristics that were different from others. It's written there: preoccupation with failure, a reluctance to simplify, a sensitivity to operations, a commitment to resilience, and a deferment to expertise. And the people who are talking about this are Wick and Sutcliffe. I have 1 minute left, so I don't have time to really go into detail to talk about that. I will tell you that they have really done this for industries outside of healthcare. What has happened, on the other hand, is that the Joint Commission in the United States, they've taken those learnings about high reliability organizations, but they have also adapted it and created a framework for high reliability for healthcare organizations. And basically, we focus on 3 things. Firstly is leadership commitment. Second thing is really developing a safety culture. And thirdly is using robust process improvement tools. And we have also developed what we call an assessment tool for organizations who want to start embarking on the high reliability pathway. So in the United States, this tool is available to all Joint Commission accredited organizations in the United States. I think about 600 over organizations, hospitals have already started using this tool to improve. Again, this is not a 1-year project. Some of these organizations have been doing this for at least 5 or 6 years now. It takes a lot of time, but you can read more about this as well as the document that is the foundation behind high reliability in healthcare in organizations. And I will say that it's really important if you're an organization that wants to focus and move forward towards getting to 5 and 6 sigma levels of quality. So I want to conclude by saying there is a lot of competition right now, both in medical tourism providers, in healthcare, as well as among countries that are providing medical tourism. My argument is that placing quality improvement at its core, healthcare organizations can achieve cost leadership, differentiation, as well as focus in order to build a sustainable competitive advantage. I think it's very well and good when we focus on quality improvement. We need to focus on standardization first, especially at the 3 and 4 sigma level. But beyond that, you need to make sure that you put in as much technology as possible in order to help humans be better humans, but also beyond that, principles of high reliability, if you're going to have your organization get beyond into the 5 and 6 sigma level of quality. I want to end there. It's again my honor and privilege to be here to speak to all of you, and I'm happy to answer any questions now or in the future. Thank you very much.